First of all, I would like to thank Professor Keen and all the colleagues from the Asia Pacific Association of Pediatric Urology for this honorable invitation to talk to you about complex reconstructive pediatric urology and also in utero effects of antenatal surgery of myelomenincocele in bladder function. I'm Antonio Macedo Jr. I'm a pediatric urologist in Brazil, Federal University of São Paulo, also in charge of the NUPEP group for pediatric urology. I'm associate editor of the Journal of Pediatric Urology. And today I'm going to tell you about the function, bladder function after in utero myelomeningocele closure. We are aware that two hit hypotheses in myelomeningocele. First of all, the damage created by the disease itself and also by the environment of the exposure of the nerval roots in the myelomeningocele defect. So it was the hypothesis that in utero surgery would bring advantages for those patients. In 2011, the MOMS study was the first one who showed, doing a prospective study, advantages of fetal surgery in regards to a reduction in the need of ventriculoperitoneal shunts, according to the postnatal surgery, also a remarkable improvement in motor status. We in Brazil had already some experience in our university with some cases done before the MOMS publication, so we were just ready to go. And this paper from our fetal medicine, Professor Boron, shows that in 2018, he published 237 cases done in utero, showing that our group in São Paulo is one of the most experienced in the world. Also because our neurosurgeon is also a precursor in other surgeries in fetal surgery. So we are in the best scenario possible in a university hospital, in a spina bifida group, and we could use and profit from this opportunity in this group, working together for myelomeningocele. And one of the advantages of our group is that we can provide urodynamics evaluation just with the medical consultation. So all data that we have, urodynamics, is really reliable and done in the same device by the same group. You look here, you see that there were pre-MOMS studies that didn't show advantage. After the MOMS study, we were the first to report on a small preliminary series showing no improvements in bladder function, although the MOMS group, the urological MOMS in 2015, showed some advantage, also the Swiss group, but we were very not having these nice results. And we were already showing our data in Congress around the world, for instance, the ESPU 2015 in Prague. And this is the publication, the first publication. When you look better in the urological MOMS study, you will see that the way they designed their study, their objective, their outcome was need of CIC by 30 months, but the criteria for using CIC was not very clearly defined. And also, most patients, after being outside from the primary hospital for urological follow-up, they were done by multiple care providers. So it's very heterogeneous data. And they don't know when they did the video urodynamics, and moreover, we don't know where, and video urodynamics were done in different devices by different methodologies. And they just simply outline the reduction in the CIC group in the fetal surgery, which is not our experience. Because at the same time, in 2015, we published our first 50 cases prospectively assessed. In this paper, we also had the opportunity to provide this bladder categorization system that can make it very objectively the groups that we have after surgery. So you can have the high risk group, which is the group that has a higher pressure, overactive bladder with the detrusor leak point pressure higher than 40 centimeters of water, or also high filling pressures above 40 centimeters of water. Those that leak during the cystometry, they were leaking either because of simply the leak point pressure or some hyperactive contractions of the detrusor leaking at low pressure. So we could preview the behavior of this group as the incontinent one. There is also one group which is underactive bladder, no contractions and residual volume, and then so the normal group which is stable, no contractions, and can void without residual volume. So in our first publication, in 51 cases, you see that we had with a mean follow-up of 40 months, but at first presentation, the predominance, 56% of patients had a high-risk group, and 37.5% had incontinent pattern. So a minor group with underactive bladder, but that means that we have more than half of the patients, 56% with high-risk group. It's the group that has high risk for renal damage, and also one group which is low risk for UTIs, but that will have incontinence throughout life. And we'll discuss this in my second lecture in the Congress. So we continue to follow those patients prospectively, and then we publish our first 100 cases. This is how the patients, when they started, you notice here, the average of patients per year. And again, the pattern of the bladder still remains the same, or 52% high risk, 27% incontinent, 5% underactive. And we could notice very clearly that the high-risk group, which is in blue, is the one who has higher grade of hydronephrosis and also vascular reflux. So this is the group we have to treat very accurately. And very interestingly, this group from USA, from Texas, they made the same criticism that we appointed here. While the MOMS trial is limited by heterogeneous follow-up, the Federal University of São Paulo has published its single investigator prospective urologic assessments, and that's one of the advantage of our data. We see that there are alternatives. Now there are authors doing fetoscopic surgery. And we also recorded that there is no influence of the fetal procedure in terms of age at birth. And it does not affect any function of the bladder, although there is a trend for prematurity. And this is the first paper that showed the fecal and urinary continence in patients at least with 5 years of age, followed prospectively. And you see here the prevalence of high-risk incontinence, but 85% are under CIC. Only 3 have no leakage, and most of the patients have fecal loss, so this is a very severe population. And we could attest that even at 5 years follow-up, almost 80% had some sort of abnormal bladder patterns. Incontinence, 85% on CIC, and fecal incontinence at 75%, 78%. The second study from the MOMS group wanted to know, they reported in contact family at 6-year-old children, asking for renal ultrasound and video urodynamics, looked for continence, CIC, surgery, if they were about to void voluntarily. But very strange in the methodology of this paper, they don't state clearly if they were seen or they were contacted by phone, and how they assess the data. They put here alternatively, telephone interview with parental reported urological outcomes. They were offered video dynamics where there is no objective data, and there was no strict sense for beginning CIC. And when you look on the data, they don't report data very clearly, And then when they compare Euroflow, they compare 9 patients from prenatal with only 1 from postnatal. So at the end, they agree with our previous information that urological outcomes should not be the sole impetus to perform in utero reclosure. So we reviewed our data retrospectively before the MOMS publication. So we had patients followed since 1999. We compare with this fetal group. And to make it more comparable, we select from the postnatal patients presented at the first time with less than 12 months. And we did this publication. We reviewed the first 3 urodynamics, 3 urological urodynamics, all the all the radiological workup, renal sonogram, VCUG, and urodynamic evaluation. Patients were very comparable in terms of age at first presentation with the subgroup, 5 months to 4 months, and very comparable data in terms of thickening bladder, hydronephrosis, the incidence of vesicoureteral reflux, showing that it doesn't make any big difference in terms of bladder behavior. Only the fetal surgery has a higher rate of fetal detrusor hyperactive. And even when they were treated according to the same protocol, we noticed that there is a very similar evolution. You see here, the high-risk group trend to improvement in the function, and the incontinent group and normal group remain the same. So in utero myelomeningocele cell has limited benefits to bladder function. Early categorization of bladder pattern is essential. Hypocontractile and incontinent patterns do not trend to change over time. Very interesting, the Swiss group also, who was reporting improvement in function, when they follow patients for a longer follow-up, you see here the abnormal bladder patterns, neurogenic, improved, and the normal bladder patterns reduced. So they conclude with time that, and the very similar data comparable to war, that demonstrate that the positive effects of the surgery, fetal surgery, are very limited with time. Based in our prospective data, we were able to record from the beginning the incidence of surgery in this prospective study, and we noticed that following 122, we found an incidence of 10% of surgery after 5 years of old, and if you consider only the high-risk group, it's 13% of surgery for this group. We do surgery differently. This is the Macedo procedure that I will show with more detail in my second lecture. So in conclusion, myelomeningocele in utero myelomeningocele closure is the gold standard for myelomeningocele treatment nowadays. Bladder function is not influenced by the procedure. Individualized approach is similar to the previous MOMS area. We can expect 85 to 9% bladder function abnormalities. 60% of patients are going to respond to conservative treatment, especially for the high-risk group, and an average of 12 to 15% of surgery need in a meal follow-up of 4 years. I thank you again for the opportunity, and I'll be available for discussion. Thank you very much.